Thank you, Minho. We'll go on to the next speaker. I'd like to invite Professor Yeo Koon Kyung to talk to us about how IVUS imaging or intravascular imaging guided his case.
Thanks very much, Hui Shim and Chairs, and it's a real pleasure to be here at SIF. Um, this is I've been asked to talk about rotablating the left main, consideration, tips and tricks, and I like this topic because we don't have to have too much data. So these are some of my disclosures, and I want to start off with this statement from the North American Expert Review on RA. This was back in 2019. And I want to highlight the two key points. One is that rotablating the left main is high risk because of the large territory of subtended myocardium, and that meticulous technique is required. So just very important. And I also like to take reference from this Japanese consensus document. It is an expert consensus document which tells you that there are limited data on this topic. And the figures here highlight some of the key aspects, and that is what we don't want to see. In one case, the top figure, the top illustration, the rotablator goes out and cause a neoramus, horrible thing. And of course, the other thing, if you have a very bad wire bias, you can have a deep cut to the lateral side and have a trough, which you don't want to see. And I have nice illustrations for you shortly. So now back to some of the considerations. I'd like to package them into the following. What are the clinical considerations? When I'm referred one of these patients, I look at the following. The age. If this patient is 99 years old, I say, you know what, let's just do enough to get the patient home to celebrate New Year, and that's pretty much what I want to do. If it's a young patient, I try to do more. What is the EF? What about the clinical acuity? Is the patient stable, unstable, or is this an emergency? Is the right coronary artery patent? And this is, of course, tied to the urgency of the case. And what kind of vascular access do I have? And do I have access to balloon pumps and mechanical circulatory support? I look at the clinical factors. Is the patient an end-stage renal failure patient? These patients are really difficult to treat. There are all sorts of access issues, and calcium is a big problem. What about diabetes? And what about the presence of peripheral arterial disease, which may hinder your desire to put in an intra-aortic balloon pump? And I think when I do these cases, I have three thoughts in mind. Success, perfect success, versus how fast can I get it done if the patient is unstable versus perfection. And we all know Voltaire's quote that perfect is the enemy of good, but I think also for many of us in interventional cardiology, the enemy of good is beautiful. What about anatomical considerations? I've already discussed the issue of dominance, especially whether the right is occluded, whether the nature of the bifurcation is it, what kind of Medina classification is it. And in my mind, the worst case scenarios are, other than an unstable patient, are those with a left dominant system or RCA-CTO with a poor LV function and 111 disease. I must say that for me, the clinical goal of getting the patient out alive overrides clinical anatomical perfection. And lastly, I want to make sure that there's no thrombus present when we want to talk about rotablation. Other broad principles that I take into consideration is that, as you heard from our previous speakers, intravascular imaging is important. But for my practice, once I know there is calcium, I generally stick to familiar strategy. I don't like to spend too much time imaging, except for optimization or final check. And these are some of my tips and tricks for rotablating the left main. To me, the LED is the priority. And therefore, in general, I will preserve the LED above anything else. Is complex bifurcation strategy expected? And you've already heard some of the bifurcation strategy for dedicated or provisional stenting. Is the osteo left main or proximal left main involved? And that helps me determine my choice of a guide and whether I need a side hole. Is the circumflex or distal left main involved? And often in that case, I tend to rotablate the circ first, just because of angulation and wiring issues subsequently. I put that in inverted commas preferences because this is a rather data-free zone. And just again from experience, that is that can I avoid rotablating the left circumflex? If I can, I generally prefer not to because of what you saw with some of the wire bias, some of the complications that might occur. Can one navigate the tortuosity of the circumflex? And if rotablating the left main into the circ, I tend to use the rotor extra support wire, the smallest burr. But I must say that there's substantial expert opinion variation when I talk to other colleagues in the field. Some prefer a floppy wire and others go with a larger burr. And what about the trough that then occurs? It is usually okay. I'm not too worried about it, but I'm more worried about the neo-ramus that might occur if you use a floppy wire. After rotablating the circumflex, we then have to decide whether the LED needs rotablation. If yes, we generally can remove the circ wire and then rotablate the left main to the LED. But on very, very, very rare occasions, you can rotablate the LED if you are confident of not touching the circ wire, and I'll show you an example of that. These are preferences again. Usually a 1.25 burr is enough. Sometimes you need a bigger one, but I tend to use this in combination with IVL therapy or some form of scoring or sculpting balloons. But obviously, if there is a big nodule, bigger burrs are needed. One stand, two stand, you heard the discussion, but nowadays we have the option of hybrid therapy, and that is a topic for another day. I think, as you heard from Dr. An, there's an issue of the presence of osteal or proximal circumflex disease, whether you have adequate circumflex preparation and how stable the patient is. And what if there's a deep trough? Well, the DCB might not work and the risk of perforation is there. It looks ugly and you may need a dedicated two-stand approach. Now, a lot of talk. Can I illustrate the cases? I've only 6 minutes left, so I'll go through as many cases as I can. Case 1. So this patient has disease in the circ in the LAD, but you can appreciate it's very calcified. There's mid-LAD disease. I think there's one figure that I forgot to show you. Maybe go back one more. Yeah, sorry. There is obviously. Sorry, I need to go back. Give me a second. I think you can have. I think you have to go back a bit more so the videos will run, or they won't run. Can we go back? Let's see whether I can get it to go back. Okay, never mind. I rotablated. There's left main disease. This is a 1.25 burr, a JL35 guide. You notice there's a balloon pump in place. Sorry, I think the figures were in the wrong sequence, but you can appreciate the left main disease and the angulation of the circumflex. Couldn't really get the burr beyond the circ, and the main problem was the lack of guide support. So I did what I could, tried to rotablate the LAD, no support. And so this is one case which I had no choice but to give up everything and came back with I'm not sure why it's not running. Give me a second, one more time. Okay. Can we help me run this? For some reason, it's not running. Good. So what do you do here? So this is the trough from the initial rotablator. So this is the trough, and I've already mentioned that. In this case, remember, I had no guide. I decided to take a chance. I took out the guide, changed it to a M plus guide, rotablated the LED 1.5, balloon it, shockwaved it, stented it, left the stented it near the ostium, and you can see the chest path there, no perforation. And then I went back with the circumflex again, despite the trough, and then used a bigger burr, managed to burr it all the way down. Scary, I know. Uh, balloon it, stented it. And I think the reason why I stented is because really there is that trough, and one really doesn't know how it will behave. Rewired the LED and converted this to a culotte. I wanted it to be initially I was hoping to drug coat balloon it, but I don't think we would have a good result. So this is the final result. LED is fine, and this is the final result. Very ugly looking, but patient went home, and I'm going to have a recheck angiogram in a few months. So this is one example. So my thoughts is deep trough, do we dare to leave it alone? Will you DCB it? Can you stent it? Would it work better with a rotor floppy wire? We can discuss it later on. Would OAS work better? I'm not sure. And do we dare to rotablate with a bigger burr after the first burr looking so ugly, right? So some thoughts for us to discuss. Case 2, high risk PCI, bad access, tortuous anatomy, disease everywhere. And I think the left main disease is more visible in the right panel in the LAO-cranial. In the distal left main, there was an angulation in the distal LAD. That's why there's overlapping vessels. Anyway, rotablated. And I just want to illustrate this case because the LAD PCI is fairly straightforward, and I had to use a shockwave, etc., to help with managing the lesion. And I just want to show the circ, there's disease, but this was what we did with the circ ballooning, and eventually using a drug-coated balloon. And the reason why I did that rather than standard is because of the angulation. I think we appreciate the angulation and the difficulty in this case of even just advancing the balloon across the circumflex. So in this case, I accepted perhaps not a perfect result, but got the patient home because of that. And you can see that the left main into LED continue to have calcium, and we had used shockwave and all sorts of other technologies to manage that. Now, given the time considerations, I won't go into. I will only have time for one more case to illustrate some of the discussion. Um, this is a patient that was done as a live case at Sing Life, and you can see there's very bad osteal circ. We rotablated a lot. We used shock wave. You can see the wasting remaining. Loss of shock wave. I'll cut to the chase. I rotablated again and went with a 2.0 burr, shock wave further. And this is what we used. 3 rotablators, 4 shock waves, a lot of balloons, and it was still like that. So what did I do? I just stented the left main into LED ostial, and then I just drug-coated balloon it. So the result is acceptable. The patient came back, had some restenosis after 6 months, but eventually did fine. I want to just say that this is a culotte stenting from before. Cipher stents, you can rotablate across for left main if you need to, and we did that with a decent result. I'm out of time, so this is the case where we were able to rotablate with another burr, with another wire in the circumflex. So this is the final result. So I want to end off with these final comments. I think when we do rotablator of the left main, there are clinical and anatomical considerations. Choose a larger guide if possible. Use imaging to guide final results. We need to consider success versus speed versus perfection. And I generally rotablate the circumflex first. Do use your other tools, whether it's IVL therapy or shockwave. And then we do need to understand some of the science behind the choice of dedicated bifurcation stents versus hybrid F-main PCI with drug-coated balloons on a case-by-case basis. Thank you very much.
Thank you. Lots of pointers to discuss, but let me just start with one. So what is the mechanism of the trough you were mentioning about? Because I don't see any imaging at the end of the procedure, which could have given us some kind of insight into what's going on here.
Yeah. So in that case, I think a trough caused by the wire bias, and this case was unstable. And this was a culotte stent, and I was actually quite fearful of disrupting it with further instrumentation. The plan was to bring her back in a few months' time to do a relook and hope that that trough, and I suspect extension of blood into the adventitia, we would have to relook on imaging. But I didn't want to do too much, frankly, at that time because it was an unstable patient.
Yeah, for first case, do you try to the non-covalent balloon or cutting balloon first before you use the rotaplator?
Yes, we did. In fact, we tried to just even get a 1.5 balloon through. It wouldn't even cross. So it was very tight in the proximal segment. So that's the reason why in the end we just had to. Well, I was hoping that we didn't have to rotablate the circ actually. Yeah.
Fantastic cases, KK. So regarding the rotator circ, sometimes it's very scary. Like you mentioned in the first slide, sometimes the wire will prolapse and then get perforated. And then using wire bias sometimes is different between one patient and another because of the angulation. So I'm surprised that you choose 1.25 balloon because it's easier to get perforated theoretically. So what we do in our hospital, we just do a half rota, not pushing the rota all the way to the circ, half rota, and then do based on the imaging, whether IVL or scoring balloon after that. Thank you.
You show us the very dramatic cases. The one of the principle, Dr. Han's presentation, we will do the one stand or two stand. Imaging is very important, but in your presentation, I didn't see any imaging before the procedure. And the lesson from your first cases, there is a hyperacute angle and the calcium. Okay, this is a good indication for the load ablation, and the final result is that the acceptable for me is very fearful appearance. So lesson is no, don't do not do the load ablation in the similar cases.
Okay, so
Thank,
thank you
thank
very
you.
much, KK, for very interesting cases.